Good morning, everybody. It's a pleasure to talk to you about the molecular part in this discussion. And these are my disclosures, which are related to this topic. On the next slide, I will rightly come into the center of this topic after the nice introduction by Jacqueline. The molecular part is related to the question, where are we standing with molecular MRD detection in AML? And I think this is an important aspect when considering that we are using molecular MRD assessment already for almost 20 years in other diseases like CML and ALL. What are the differences? Why are we having such a trouble, and why is AML much more complicated? And I try to delineate some of the aspects which make AML different compared to CML and ALL, which is, of course, the target. So, for example, in CML, we have only measurable, which is detectable in every patient with this disease. In the ALL setting, we have either the immunoglobulin IgVH T-cell receptor rearrangement or BCR-ABL. This also translates to the method. So for one target, we only use one method, which is qPCR in CML, and in ALL we have qPCR and more next generation sequencing. We, over the last 20 years in CML, have implemented standardization, mostly driven by the UTIS activity. And similarly, in ALL, we have the Euroclonality initiative, which brought up important standardization measures. And this drove further the idea that we need cutoffs which can be used for clinical intervention, which is, for example, the major molecular remission, or MMR, the MR4 and MR4.5 now for treatment-free remissions in CML. We have the 10 to the minus 4 cutoff for more intensive treatment in ALL. And we have also new treatments which can be applied. For example, in CML, if we have a failure of the first generation TKIs like imatinib, we can move on to second generation or third generation TKIs. And we also have very defined measures for the blood, for the materials, which is blood in CML and preferable bone marrow in ALL. Coming to all these different aspects in the AML, you see major differences. So we have a plethora of different targets in AML for molecular techniques. We have methods which are still discussed, and I will come to that in a minute. Standardization is lacking. We are on the way to do this, but we are far away from being successful so far. And that also brings up the idea that we don't have well-established cutoffs. We have to work on that. So far, we had only stem cell transplantation as the only treatment option, but I think this is something which is moving forward fastly with all the new drugs come into place, and we still have the discussion which is the preferred material. So in AML, most of these variables are still defined. What methods do we have? We have heard already a lot about the applicability of flow cytometry as a very attractive method, being broadly applicable in the majority of patients, with a sensitivity which is clinically useful, 10 to the minus 4, 10 to the minus 5. Very rapid turnaround time, but still some limitations, of course, with the sensitivity and the standardization, which is ongoing. With the molecular techniques, we have, at present at least, 3 major fields. qPCR, I think, is a well-established procedure, but has, of course, the limitation that only certain targets can be used for that. These are the core-binding factor translocations and NPM1. That leads to the point that only about 50% in older patients, even less than that, are applicable, are targetable with that. The sensitivity is very attractive, 10 to the minus 5 in the majority of patients, some patients even less than that. Turnaround time is clinically meaningful, but the limited applicability, of course, brought about the idea that we probably need newer methods, and I will focus mostly on next generation sequencing as an attractive method which might be useful in the future to overcome several of these limitations, because it is probably applicable in almost 100% of patients if you not only think about panel sequencing, but in the future about whole genome sequencing. That might be a very attractive option to further increase the applicability of this method, and most patients might be eligible for that. At present, at least, the sensitivity still is limited, and it takes quite some time and is very costly, but I think all these issues might be solved in the future. Jacqueline already mentioned to you the activities of the MRD working party of the ELN, and we were successful in having a first round of recommendations published 2 years back, where we focused on the at that time available methods and things that could be recommended. And we all agreed that qPCR is the method of choice in patients having well-targetable lesions like the core binding factor translocations NPM1. Other targets like WT1, for example, is only recommended if no other markers are available. The mutations like FLT3, ITD, TKD, RAS mutations, IDH1, and so on should only be used as secondary markers, in certain markers like DNMT3A and A6L1 and also TET2 are not really well established, because they are belonging mostly to chip clones. I will come to that in a minute. We defined molecular progression and molecular relapse. We also defined the sampling intervals, and we recommended evaluation of MRD pre and post-transplantation. To give you an idea of where we are currently standing, I focused on one target, which is actually the most common target in AML, which is NPM1. And you can see a compilation of several larger studies focusing on the impact, the prognostic impact of NPM1 mutations in patients with AML. And what you can appreciate is that almost all studies identified NPM1 positivity as being predictive for either overall disease-free survival or the incidence of relapse. What you can also appreciate is that the cutoffs used there are really differing between these studies, and that's something which is an ongoing problem, because when we are not able to define a common cutoff, we will not be able to prospectively use these markers. And one of the last studies published was by the French Alpha group, and they used a cutoff which is probably the way to go, where they defined their cutoff based on the log clearance based on the initial MRD level, or the level of NPM1 in the diagnostic sample. And you can see that they could identify that a clearance of 4 logs or higher is discriminative for a long-term disease-free survival and overall survival. And why this is an attractive option is illustrated here. What we performed is one of the first round-robin tests for NPM1 within the ELN working party, MRD working party. And on the left-hand side, you can see results which were distributed, samples which were distributed to participants, almost 20 participants around the globe, and they were asked to report back their data based on the NPM1 level. And you can see that they are varying widely, but when the same results were transferred into a log scale, you can see that there is a very attractive and very decent correlation between the individual results. What about persistent disease, and how can we use that? I think a very attractive study was recently published by the AMLSG group, where they could actually show that we need cutoffs. When you only look at positivity or negativity, you can mislabel patients as being prone to relapse, and only if you define certain thresholds. In this study, 150 copies per 10 to the 6 copies of beta microglobulin, this was discriminative, but not if you look at just positivity or negativity. Coming now to the novel techniques like next-generation sequencing. Of course, next-generation sequencing in theory, by just scaling up the read counts, could detect alterations at a very high sensitivity. But the problem is that due to the technical artifacts which are generated or produced during the preparation of the NGS library, artifacts are induced where you have wrong positivity, false positivity in especially single base pair variants, which is the most common alteration in AML. And you can overcome this only if you apply certain techniques, which are so-called error-corrected sequencing methods, for example, using unique molecular identifiers, where you can subtract the background, which is shown on the left graph, and if you apply the error-corrected sequencing, you can see the correct positives in the middle graph, and that gives you a very decent and linear correlation. First data without error-corrected sequencing applying next-generation sequencing in AML were published by several groups. Here are the data published by the Hovon group, where they could also show that not only we have a technical issue, we have also a biological issue with this, is that certain mutations can pop up after treatment, although these patients will not relapse. And these are especially the so-called DTA mutations, referring to DNMT3A, TET2, and ASXL1. And these are not predictive for outcome, but if you subtract that, you can identify patients at relapse. And similar methods were also applied in patients before transplantation. And Chris Hourigan from the NCI did such an approach, and he was able to show that he could detect alterations at a sensitivity of 0.1%. And if he did so, he could delineate in a randomized study that a retrospective analysis of a randomized study that RIC transplanted patients were not benefiting if they still had MRD detectable at the time of transplantation. Coming now to new approaches, we did a study where we combined next-generation sequencing with CD34 sorting to increase the sensitivity, and that's a very attractive tool. We did so retrospectively in the context of the RELAZA study, which was recently published, and we could see that we can increase the time to predict outcome, predict relapse in patients up to half a year or more if we apply this, and we can reach sensitivity of down to 0.001%. Novel techniques which might be applicable in the near future are, for example, single-cell sequencing methods, very attractive tools, still at the research level now, but they can there you can identify mutations within even a single cell, which will give you probably the opportunity to combine flow cytometry with sequencing methods and to get an even deeper insight into the mutation background of a patient. And the first study on this was published by the Stanford group, Ravinder Majechi, and they could actually show that the complexity of a patient after treatment gives you strong indications whether a patient is prone to relapse or not. Patients with a lower diversity have a much lower risk of relapse and a better survival than those patients with a higher diversity. Coming to the conclusion, so I think the molecular MRD at present represents the most sensitive approach for MRD detection, but still has the limit of the limited availability of certain targets. Next generation sequencing has the option to broaden this in the future, and we hope to have this implemented in this setting. We need further improvement to do so. Chip lesions, as well as the technical aspects which I mentioned to you, have to be taken into account, and we have new developments on the horizon which will make this field even more applicable. And with that, I would like to thank you for your attention and happy to discuss these issues with you.